January 13th, and I just want to start off by welcoming you all by saying Happy New Year to you. Hard to believe that we're already half of the way through our first month of this new year. And I'm also noticing that the days are getting longer and there is actually some perhaps almost daylight, just a little bit as we're starting our town hall this evening, so that's always a good sign. This is a fantastic photo by Dr. Susan McDonald, family physician in Regina, who through Twitter I discovered shares a love for birds with me, but unlike me, she's a fantastic photographer, and I'm really grateful that Dr. McDonald sent slides to us. And please, if you have shots of Saskatchewan that warm your heart this winter, please send them in and we'll use them in the town hall. We'll go on to our next slide. We're just working our way through building a complete slide deck for all of us this evening, but we're getting there. First reminder, we do record the town hall and we do post it publicly on the Physician Town Hall webpage. And to help all physicians in the province have access to this information, it is posted in a public-facing website. Your names, your polling results, and any Q's and A's that are entered through the chat boxes are not shared, but anything spoken or shared on the screen is captured in that recording. We always ask that you sign in using your full name, first name, last name, no nicknames, nothing like that. And that's just so we know who's in the room and we can have safety and a collegial place to do our work this evening. If we do notice that for some reason your WebEx sign-in has put in initials or a name that we can't really figure out, we will ask you to identify yourself. If we're unable to make that contact, we will exit you, and you're always welcome to rejoin using the same link. Just please check your name is entered into the registration appropriately. As always, we'll do a live poll probably near the end of tonight's WebEx. We want to hear from you about how you're doing and how we can always improve our town halls for you. And as always, we want to hear from you throughout the WebEx this evening, throughout the town hall. We have our live question and answer that will be flying, I think, this evening. So we'll move on to the next slide, and I'll talk a bit about our panelists that are joining us this evening. As always, we have a whole panel of panelists that are going to be available and chatting with you through the Q&A throughout tonight's town hall. They'll be introducing themselves through the chat, and in real time, they'll be answering your questions. And if we do have time at the end, I think we're a bit content heavy this week because there's a lot going on. So if you have questions, we'll answer them. And if we have time at the end, we'll have a live discussion if possible. Next slide, please. Always important to pause and recognize where we are in our history. So I want to acknowledge that today I meet with you on Treaty 6 land, which is also the traditional homeland of the Métis. And I commit to learning more about my shared history, my part in it, and my opportunity to improve the health outcomes and experiences for all people in Saskatchewan, recognizing our history and the colonialism that has impacted Indigenous peoples. I pay my respects to the traditional caretakers of this land, and I ask that you think about which part of our province you're on and which treaty land you're on, and the connection to the homeland of the Métis. We'll move on to the next slide. Just a reminder, we're accredited for both Royal College and CFPC, and that will introduce some changes to the town hall. Certificates will be emailed to all participants right after the town hall through the WebEx survey evaluation and check-in. So I'll remind you of that at the end, and we'll just move on to the next slide. So here's my disclosure. I have no relationships with any sponsors. We can go on to the next slide. And I have no conflict of interest. The speakers today have received payments, many of them, as employees or contractors of the SHA. The SHA does not benefit from any products that will be discussed throughout this program. There is no financial support of this other than in-kind support from the SHA. On to the next slide. And we do try our best to mitigate potential bias. Next slide, please. So like I said, we have a content-rich and a very, I think, important town hall this evening. We do have a special guest. I'll be introducing Dr. Angela Rasmussen in just a second. But we will going to talk about our surge planning, our offensive update, our vaccine strategy, the defensive strategy highlights, safety updates. Of course, we'll pause at the end to talk about wellness and practice techniques. And I'm hoping that we'll have time at the end to summarize it all up and have a live Q&A. On to the next slide. So I am going to introduce Dr. Angela Rasmussen, and you're going to see a black screen just for a second. A real screen will be coming up in just a bit, but we're just going to change slide decks. It gives me great pleasure to introduce Dr. Angela Rasmussen, who truly is a world-leading virologist working currently in our home province. You will know that VIDO, Vaccine and Infectious Disease Organization at the U of S, has been an excellent partner throughout the pandemic. And I'm really glad that Dr. Rasmussen is with us. I love this description that she provided of herself. I am a virologist studying the endlessly fascinating struggle between host and pathogen. And another thing I found actually just today when I was skimming my Twitter feed this morning, as I always do, is one of our local professors in Saskatoon described Dr. Rasmussen as having a brilliant mind and a sharp pen. She is a virologist, as I said, at VIDO, with her research focusing on the role of the host response in viral pathogenesis, and she has a particular interest and expertise in emerging viruses such as avian flu, Ebola, and SARS. Dr. Rasmussen graduated and has trained at several impressive universities, including Smith College, Columbia, and the University of Washington. She is a member of the World Health Organization Ad Hoc Expert Committee for Preclinical Models of COVID-19. She sits on many editorial boards of prominent publications related to her area of expertise. And one of the things that you might know the most about Dr. Rasmussen is she's a prolific science communicator, very active on social media and in the mainstream press. You will see her in the New York Times, the Washington Post, CNN, you name it, if it's reputable and worthy of listening and reading, I think Dr. Rasmussen has been there. So with that, I could speak a lot about many other things that Dr. Rasmussen has accomplished, but I'd rather hear directly from her. So with this, I'm going to hand over to Dr. Rasmussen, and she's going to speak about Omicron, and that's something I think we can all be very interested in. I'm going to hand it over to you, Dr. Rasmussen, and then once you're complete, I'll take back over. So welcome, and my thanks to you tonight.
Thank you so much for that extremely kind introduction. It's really an honor to be here and be presenting and talking to my own community's health association. So I'm just delighted I could be here tonight, and I do apologize that my PowerPoint presentation was a little bit last minute because this has been a very busy week, and it had a lot of images in it, even though it's only 20 slides. So I end up having to do this over a PDF copy of my slide deck. So hopefully that won't be too distracting. But you all just heard about who I am. I'm here. My primary appointment is as a research scientist, starting my lab up at VIDO. That's one of the things that's been keeping me so busy this week. And today I'm just going to give a little bit of an overview of some of the emerging molecular, virological, and immunological features of Omicron, the things that everybody is kind of wondering about it. And even though Omicron has only been with us for less than 2 months that we've known about it anyways, there's already quite a lot of data. There are still many knowledge gaps, so I'm going to do the best I can in covering some of this, and I'm happy to discuss any of this further during the question and answer session later. So next slide, please. I do have a few disclosures. I do some consulting work. I've also been a paid speaker and accepted honoraria for giving seminars and talks. I'm a paid contributor to a variety of different newspapers and magazines over the past couple of years. I also own some stock. And my research now is currently just funded by both VIDO, the province of Saskatchewan, so I should update this section of it, but also through CIHR, as I am a pillar lead for COVARNet, or the Coronavirus Variants Rapid Response Network, In the past, my work, including some of my work on SARS coronavirus 2, has been funded by these other agencies and private foundations in the US. Next slide, please. And I would like to start my talk with a territorial acknowledgement and equity statement. And today I'm presenting as an uninvited settler on Treaty 6 territory in the homelands of the Métis people. I acknowledge and honor the First Peoples of North America and their tribal governments, histories and ancestry, and their roles today in caring for these lands and waters. And I also acknowledge the long history of systemic inequity in academic science. Two institutions where I've previously worked and trained, Columbia University and Georgetown University, were founded using profits from the transatlantic slave trade and excluded women and people of color from their academic communities for nearly 2 centuries. This has left a long and painful legacy of racial and gender-based inequality that continues to this day. And I encourage everybody who's watching tonight to consider how you can contribute to making biomedical research and medicine a more equitable enterprise. Next slide, please. Next slide, please. That one got duplicated. So I was just going to start off with a quick snapshot of what's going on with Omicron right now in Saskatchewan. Like many other places throughout Canada, many other countries throughout the world, we are on the uphill slope of another surge that is predominantly being caused by the Omicron variant. And these were the numbers as of today here in the province. The majority of cases are in the cities, in Saskatoon and Regina. And about 95% of these cases are Omicron based on PCR testing or PCR screening. As a result of this, the provincial health labs are no longer going to conduct this screening. They'll continue to do whole genome sequencing. However, most of these cases are going to be Omicron because it has largely displaced and outcompeted the Delta variant, which was previously circulating here. Next slide, please. This really mirrors a pattern that has been seen in other places, including our neighbor to the south, my home country. You see here on the left, this is a figure from the CDC. This is their Nowcast, where they take genomic surveillance data from across the country, and they put it into this predictive algorithm that tries to apply it to the entire country. And what we see here is pretty striking. The orange on this graph is Delta, the purple is Omicron, and Omicron has very, very rapidly displaced Delta, so that the vast majority of new COVID cases that are occurring are all caused by the Omicron variant. The same is true for Canada, even though we're a little bit behind the US. That's here on the right. This is a figure provided by PHAC. In this figure, blue is Delta. There are some other variants and Delta sublineages included here. The purple is Omicron, and you can see again, much as along the same time scales as in the US, Omicron has very rapidly displaced Delta as causing the majority of infections throughout Canada. Next slide, please. So all of this really does suggest that Omicron is superior, at least from a virological standpoint, from the virus's point of view, to the Delta variant, which is certainly bad news because we had enough trouble with the Delta variant. But we don't really know where Omicron came from. And here's where Omicron really starts to diverge from some of the other variants of concern. So the prior 4 variants of concern, Alpha, Beta, Gamma, and Delta, were one of 2 things, really. They were either more transmissible, like Alpha and Delta, and those seem to be the variants that were winning the variant competition, or they were capable of evading immunity, probably because of changes that increased binding affinity of the spike receptor binding domain, or RBD, to the ACE2 receptor, and that's like beta and gamma. A lot of those epitopes in the RBD are targets of neutralizing antibodies, so that's why they were more immune evasive, but they weren't really both. And they clearly, all 4 of those variants of concern clearly emerged from large surges that were occurring in predominantly unvaccinated populations. Now, this phylogenetic tree here is today's genome data from NextStrain. And what you can see here, as I've pointed out, is Omicron diverged from its most recent common ancestor, which was a virus that was circulating in May of 2020. So as we look up here and we see all these Delta sequences, all these Alpha and Beta sequences, we're seeing those variants, we're seeing the sequences come up in very close proximity time-wise to their most recent ancestor. And that is not the case with Omicron. This is a very, very long branch length on this phylogenetic tree. And that suggests that Omicron really evolved out of sight in some population that we haven't been able to monitor. So the origins of Omicron are really mysterious compared to Alpha, Beta, Gamma, and Delta. And there's a couple possibilities. So really, I think there's two hypotheses that are most credible to me. One is that it resulted from long-term persistent infection, potentially in an immunocompromised person. We know that we have seen some of the mutations that Omicron carries coming out of intra-host evolution. We've also hypothesized that this could be from an animal, and I'm going to talk a little bit more about that. So we don't do a lot of genomic surveillance in animals, and it's entirely possible too that Omicron did accumulate all of these mutations as it was being transmitted effectively silently in some unknown animal population as well. So next slide, please. But however it came about, Omicron is very, very different from the other 4 variants of concern, and you can see them all stacked up here against each other. It's not as important to talk about what all of these different mutations are, other than to point out that some of them are shared between these variants, but Omicron, as you can see down here, has many, many more compared to Alpha, Beta, Gamma, and Delta. So while some of these mutations, we know what kind of impact they have, we don't know a lot about many of these other mutations, particularly the mutations, and this is actually also true for all of the variants of concern that are not in the spike protein. So today I'm largely going to focus on the ones in the spike protein because we do know a little bit more about what those will do, and those have the most immediate public health impact in terms of their impact on vaccine effectiveness. So next slide, please. So these mutations in the spike protein do impact the protein's function, and the spike protein's function, of course, is to enable cell entry in the process of infection. So here I have a figure that one of my colleagues, Bob Gary at Tulane University, has made and been continually updating that shows the spike protein as well as many of the mutations that have been observed in other variants of concern. And I think one thing that's really notable about this that I'll come back to later is that we've already known that SARS coronavirus 2 is a very generalist virus. It can infect a lot of different animal species, but many of these mutations that have been observed, including in Omicron, are thought to be associated with an expansion of host range. So meaning Omicron may have the ability to infect other animal species that the other variants of concern might not have been able to. These are all the different parts of the spike protein. This is not super important for this, but I just want everybody to get an idea of what we're talking about. The N-terminal domain, this section here, is thought to be involved in antibody neutralization. The infectivity and fusion section, this is the S2 portion of the spike protein. This is involved in binding to the receptor, also processing this portion to expose the fusion protein and allow the virus to complete the entry process. And then, of course, the receptor binding domain is highlighted here in pink. It's on the upper right, and it's associated with antibody neutralization, infectivity, and receptor binding. Next slide, please. So what impacts do the mutations that are in the spike protein of Omicron have on the virus's actual function, the processes by which the virus replicates itself? Well, here's 2 studies that have just come out, and there have been several others using pseudoviruses that also support this. One study, the study on the left, is from Hong Kong University, and I apologize that this slide is a little bit hard to see, but basically what it shows is that Omicron is preferentially replicating in the bronchus rather than in the lung, whereas Delta and the wild type Wuhan 1 virus are better, they're more able to replicate within the lung tissue in the lower respiratory tract, as opposed to the bronchial tissue, which is, it's not really the upper respiratory tract, but it's further up than the lungs. So this paper on the left here, which is now currently under review in a journal, Nature journal, really kind of gave the first indication that possibly Omicron has different tissue tropism than some of the other variants of concern, and that it's more likely to colonize the upper respiratory tract and replicate there rather than in the lower respiratory tract, which also might explain why there has been somewhat of a decoupling in many places between hospitalization rates and case numbers. This was really confirmed by some work that was done by Tom Peacock and Wendy Barclay's groups in England. And here you see on the left, and this left series of these colored panels here, that the human nasal epithelial cells preferentially support Omicron replication, whereas the Calu-3 cells in the right panels, those are lung cells, and they support Delta replication more robustly than Omicron. So that does maybe suggest that Omicron is going to preferentially replicate in the upper respiratory tract, resulting in more viral shedding, which may also explain why Omicron is so much more transmissible than even Delta, which is already pretty darn transmissible itself. Next slide, please. And in the same study done by Tom and Wendy, Omicron is outcompeting Delta in upper respiratory tract cells. So this is the left panel again, are these nasal epithelial cells that represent upper respiratory tract tissues. And you can see that in a mixed culture, in a competition experiment, Omicron, which is colored in purple, is rapidly outcompeting Delta, which is in green. That's not really the case as much for the Calu-3 cells, which again are the lung cells in which Delta performs better. The middle panel is just Vero cells. Those are a cell line from an African green monkey kidney. Those probably aren't that interesting in terms of thinking about which part of the human respiratory tract that Omicron is preferentially infecting, but this data does seem to support that at least in the upper respiratory tract cells, it has a competitive advantage compared to Delta. Next slide, please. And Omicron, the reason that it may be replicating preferentially in these upper respiratory tract cells is that it does appear to use an alternative entry mechanism. And you can see here on the upper right, there's a picture of the plaque phenotype on these Vero cells, these monkey kidney epithelial cells expressing human ACE2 and TMPRSS2, which is a cofactor that's required for cleaving the spike protein during the process of receptor binding and entry. And you can see for Delta in these cells, Delta has a much larger plaque phenotype. Those little white spots are essentially patches of dead cells called a plaque that we use to measure infectious virus. And they're much larger than the comparable plaques in Omicron, which suggests that there's something about these Vero ACE2 TMPRSS2 cells that Omicron either doesn't care about or is just not replicating as well in them. So what could that be? Well, they did some additional work to look at fusogenicity, which is the process of fusion that's required also for entry. It's post-receptor binding entry process. Delta was seen to be extremely fusogenic, which was hypothesized to be the reason that Delta itself was so transmissible. And again, it's a little hard to see here, but these green spots indicate syncytia formation and membrane fusion. And for D614G, which is a more ancestral virus, and Delta, you see a lot of green spots, not so many for Omicron. That suggests that Omicron isn't actually very fusogenic, which is a bit puzzling because it's very transmissible. So what could be the reason behind that? Well, they looked in these human nasal epithelial cells and they treated them with either an endosomal uptake inhibitor or a inhibitor of some of these fusion processes, Camostat. And you see that in Delta, Camostat, which inhibits TMPRSS2 activity and inhibits this fusion process, had a profound attenuating effect on viral replication, but not an Omicron. And in Omicron, it seemed to do just fine with these inhibitors applied. So that suggested really that Omicron was using an alternative entry mechanism, the endosomal pathway, preferentially over the fusogenic pathway that all the other variants of concern have used. We still don't know a lot about this yet, but this also could potentially explain why Omicron is preferentially infecting some tissues and not others. Next slide, please. So the real question, though, in all of this is, does that make Omicron quote unquote milder? And I'm not convinced that in unvaccinated people, Omicron actually is always going to be milder. We certainly, obviously, immunization, prior exposure has an attenuating effect on disease severity, but it's not clear that Omicron is. According to these studies, however, it does appear to be attenuated in terms of disease severity in a few different animal models. So this was a very large study involving many groups in both the US and in Japan. They looked at body weight loss, which is an indication of morbidity, viral load, of course, both at viral RNA and at actual infectious virus, breathing function, lung pathology, and mortality in the Syrian hamster transgenic model. And they found that overall, in all these different models, multiple strains of mice against multiple ancestral viruses, including other variants of concern, including beta and delta, that Omicron was generally milder or attenuated in these animal models. So it does look like, at least in these models, it is less virulent, less pathogenic. But it's not clear that this is completely applicable to the human situation. And obviously, a K18 human ACE2 transgenic mouse is very different from an actual human being. So I think the jury's still out on this, but this animal data is encouraging that Omicron may be a little bit less virulent, again, at least in these pathogenesis models. Next slide, please. So I'm just going to finish up here, and we're getting close to the end by talking about vaccine evasion. So as I've shown before in other slides, this is just a three-dimensional model showing that there are many mutations on the surface of the spike protein at epitopes that antibodies are likely to bind. This heat map to the side, you don't really need to worry about each individual square, but it basically shows that Omicron is certainly a lot more likely to have reduced neutralization by antibodies, as well as reduced efficacy of monoclonal antibodies used as therapeutics. Next slide, please. And certainly there have been a bunch of these studies. So I am only showing a representative one here that shows that in terms of antibody neutralization, at least Omicron is very capable of evading some of these neutralizing antibody responses. There are marked reductions in antibody neutralization using either live virus or pseudovirus-based assays. And that is ameliorated a little bit here by a booster dose. That certainly does bring up those antibody neutralizing titers after a third dose compared to the typical 2-dose regimens. And what you can see here on the bottom very well is that this is a whole bunch of different vaccine combinations, which is why I chose to use this, because it really does show that really you need an mRNA booster to get this restoration of antibody neutralization, regardless of what vaccines you were using before that. It could be Pfizer, it could be AstraZeneca or Moderna, or any combination of those. You really do need that third dose to restore some of this neutralization activity. Next slide, please. And so this is just another paper that I included because it came out yesterday in the New England Journal of Medicine. And this also shows that this is pretty good at evading antibody neutralization after 2 doses of a variety of different vaccines, as well as convalescent infection. So that pretty much captures what we've been seeing in the real world, that fully vaccinated people with 2 doses, as well as people who've recovered from infection with a prior variant, are susceptible to either breakthroughs or reinfections, respectively, with Omicron, and certainly much more likely to be reinfected or have a breakthrough compared to Delta. Next slide, please. But the good news here is that in terms of the impact on vaccine effectiveness, now I'm not showing it here, but the vaccines after a booster dose remain very effective at protecting against severe disease, even though they're not as effective at protecting against infection. But what I'm actually showing here is vaccine effectiveness against infection. And this is with the Moderna vaccine. With the 2-dose series, you see this fairly dramatic decrease, that goes down to basically 0 in protection against infection with 2 doses of Moderna. That's this red line here underneath the blue line, which is Delta. But when you add a 3rd dose in the series, you actually can restore that to about 65% effectiveness against infection. So a booster shot really does not only provide really good protection still against severe disease, hospitalization, and death, but a 3rd dose can actually provide really substantial protection as well against infection altogether. So that's really the good news, and it's good news because many of us have either already gotten or are due to get. I'm getting my booster shot tomorrow. So it really was an excellent time to roll out boosters here in Saskatchewan, and people should go get them if they're eligible because they really do make a big difference. Next slide, please. And I'm just going to close right now very, very quickly by talking about some of the work that I'm doing with my colleagues as part of COVARNet and here at VITO. As I mentioned before, very briefly, we don't know where Omicron came from, and it could have come from an animal. That also means that it could go back into an animal. And since we don't want, the grandchildren of Omicron spilling back over into the human population, we are interested in seeing which Canadian animal species would potentially be susceptible to Omicron infection, and maybe inform our efforts to surveil Omicron here in Canada more effectively. Next slide, please. So this is just the last slide with any substance. That paper that I had mentioned earlier from Tom Peacock and Wendy Barkley also looked at ACE2 from different species. And this heat map, again, you don't really need to worry about what's on it. It just shows that compared to D614G, an ancestral variant, Omicron has very different binding profiles to ACE2 from different species. And Omicron does use ACE2 as its primary receptor. It hasn't changed receptors. So that does suggest that Omicron will have a different host range of different animal hosts that it can infect. So one thing my colleague Arinjay Banerjee and I are doing is taking ACE2 from a variety of different Canadian species, transfecting cells with them, and then we're infecting them with Omicron and other variants to see if Omicron can infect these animals, many of which are very important to us here in Saskatchewan because we're also looking at animals that are critical for agriculture. So we're going to be looking at animal susceptibility, and then hopefully we'll be able to do some in vivo studies as well to assess the risk to the human population in more detail, as well as the risk to the animal population. So stay tuned for that. I will be glad to share our results once we have them. We're just getting those experiments up and running now. And next slide, please, just has my contact information. Please don't hesitate to get in touch with me and ask any questions you like during the Q&A section. Thank you again for having me.
Dr. Rasmussen, I just want to say, wow, that was fantastic. I loved how you said, we've only seen Omicron for 2 months that we've really known about, but looking back, what do we already know and what is it teaching us about what we don't know and what we need to know next? So I'm just so grateful that you joined us this evening. We do have in the text Q&A a couple of questions. I'd love for you to try and answer those as you see fit. And we'll also move on to the next section of our town hall. You're always welcome to stay, and I really hope we get to talk and learn more from you in the moments ahead. Also, I forgot to say at the start, welcome to Saskatoon, welcome to Saskatchewan. If you want to have a very fascinating read using Twitter, follow Dr. Rasmussen on Twitter. I think she's got one of the best feed out there as a source of truth and a source of science. So thank you so much for joining us. And I hope you had a chance to try out some of our amazing craft beer scene. I know that's something that's close to my heart around here. So with that, we're going to move on. You would have heard yesterday through a press conference that the SHA participated in that we have, based on everything that we're experiencing and observing around the world and starting to see completely in Canada, and that we know will be coming to Saskatchewan soon, an Omicron surge plan. I'm going to walk you through kind of the top 5 elements of the surge plan. I encourage you to go to the press release, the SHA Daily News yesterday, connect with your IHICs for more information, and stay tuned, because we know that we're starting wave 5 in a much more challenging place than any other wave that we faced before. And we can talk more about that through the town hall. So let's move to our next slide. Like I said, we have needed to really think about a highly transmissible virus that I'm with Dr. Rasmussen. If you're unvaccinated, I am not convinced that this is milder. It may be milder than Delta. I don't think it's milder than wild. And if you're unvaccinated, you're most likely going to get it, and you're probably going to get quite sick from it. So we're worried about that. And we also know with the way that it transmits, we need to have as much control and surveillance as we can. And it's going to impact our workforce, either because people themselves are positive, despite their best attempts through PPE, point of care risk assessment, fully being vaccinated. We're still seeing positive cases. And we also know that people will need to stay home to take care of their kids or their family or others due to the impact, particularly on the unvaccinated, including those under ages 5. So we've needed to update our surge plan. And again, increase in demand and an increase in staff absence from work due to this variant. We've got 5 key strategies that are aimed to continue to allow and promote and ensure Saskatchewan patients get the best care possible at all times. The first one is an establishment of GO teams of medical professionals, physicians, nurses, therapists, and more that can mobilize and deploy within their areas, within their health networks, to really go to where the needs are greatest and maintain continuity of key services across the province. You know, we've needed to do that before, but perhaps at a smaller scale. And we will be looking at, and we've already seen some physician redeployment naturally to be able to continue to have services continue. And we're building teams that can do this across the province. We really need to continue to focus on maintaining acute care capacity. We're already starting with a high level of inpatient demand at this time, and that is impacting emergency department flow. And we need to make sure that those that need care in the emergency get it, and those that can be treated safely and appropriately in other settings are able to access those things. So does that mean opening up more assessment centers? Does that mean working more with physician practices? Absolutely. We want to maintain the enhancements to the emergency medical services that are already in place to manage additional demand through the previous surges. And we need to implement key provincial human resource strategies like cross-training staff to meet multiple system needs and utilizing supplemental workforce teams. So bringing in support from other ministries, other organizations, other sectors to really do an all hands on deck. And in addition to this, we do know that there is highly likely to be time-limited, targeted service slowdowns when required and where required, aiming to minimize this as much as possible, to minimize the impacts on our patients. And we know people want to do the work that they are best suited to do, but we also know, just as we're seeing in many other places in North America and in Canada, we have needed to do service slowdowns. And that's our truth, that's our reality. Next slide. So this plan is being implemented. So some of this is being planned already, like the creation of GO teams, the consideration of cross-training, all of the, always looking at can we maintain services. It's actively happening. And if we see a further increase in acute care patients, or if there's additional staffing shortages that we just can't provide care the way we want to due to self-isolation or needing to be away from work, we're going to have to do this. We're absolutely committed to the principle that the efforts to meet increased demands due to COVID, including particularly the Omicron variant, will be achieved through slowdowns only when absolutely required, and with a priority ensuring that time limited and targeted. So we're not planning on a system-wide shutdown. All efforts are going to be focused on ensuring critical services continue at the normal service levels throughout the next few weeks. But it's really going to depend on what the demands are in the public through the, how many patients we need to look after and how well and healthy our staff workforce can be maintained. Next slide. So that's the surge plan. You will have questions. You will need to learn more. Please go to the daily news. Please stay in contact with your area division and department leads and reach out, support one another, and make sure you have your third dose of your vaccine and that you're using that point of care assessment as best as you can to ensure that you're safe every day. I'm going to hand over to John Mark, and he's going to walk us through, and we'll go through to the rest of the town hall. And I'll see you at the other side. I'm just going to remind all of our speakers, we've got a lot on our plate this evening, and so if you can just focus on those key messages that you need us to be able to take home and build into our practice, and all the best. Thank you.
Yeah, thank you very much, Dr. Shaw. And I will just get into an update on our epidemiology and key messages from the medical health officer. Next slide, please. So I do not have any conflicts, and this is my disclosure list. Thank you. So as you've heard, and I think Dr. Rasmussen's presentation couldn't have come at a better time, we're learning more about this virus that appeared at the beginning of December. It's moving very fast, and the nature of this wave is really, really different. We've gone through other waves. Delta was particularly challenging, but right off the bat from Delta, we're dealing with the Omicron wave. We haven't been able to receive our latest effective reproductive rate estimates for Saskatchewan, but we believe we are in the stage of exponential growth just based on our test positivity and the number of positive tests. We are seeing an unprecedented number of positives coming in. And we know from our wastewater sampling in various parts of the province, particularly in the big urban areas, they are seeing huge surges in numbers. More than 90% of the screening for SNP samples for the variants of COVID that have come in the last couple of weeks, by the end of December, greater than 90% of the provincial samples were classified as Omicron. And generally speaking, we can say COVID is circulating very widely in Saskatchewan. This is a very, very infectious variant of COVID, so everybody's at risk. Some of our messaging has shifted and our strategies have shifted, and we'd like everybody to take any respiratory symptoms, any cold-like symptoms must be taken seriously, no matter how mild. And your first assumption is it is COVID until proven otherwise, and you do need to self-isolate. Do not go to work. Stay home. If you're able to test at home. A rapid antigen test is a good first step, because a positive antigen test should be acted on. Some of this increasing surge has come with challenges for us as a system because of huge demand. Our PCR testing in the lab, in terms of sample collection, has been really, really oversubscribed. And we believe we might only be seeing the tip of the iceberg, even from our PCR test reports. So, we may be underestimating, if we just look at the daily case rates, I think we're underestimating the extent to which the Omicron virus has come into the province. But we do expect that we will see high peaks of this number. And part of the challenge with Omicron is it moves so fast, and rapid transmission in a small time frame even if we have a milder version of COVID, it just represents higher numbers of individuals who, if they present at a very tight time frame into healthcare, this is really going to strain our capacity. So our overall recommendation for Omicron is Omicron will create pressures for us both on the offense and defense strategy. There's going to be a lot of disruptions because this is not only going to be a surge in cases, but this is also going to come with attendant human resource constraints because of staff illness and staff absenteeism because of taking care of a loved one who might have Omicron at home. Next slide, please. So this is looking at the Canadian epidemiology and the case rates per 100,000. And this is the report of January 11th. And the map on the left is all the provinces of Canada. And you can see we're all dark blue, which really shows not only is Omicron widespread in the province of Saskatchewan, it's widespread in Canada as well. As much as Saskatchewan is now the second lowest of case rates amongst the provinces, following the province of BC, but we know that PCR testing has come under considerable strain, and our testing rates in Saskatchewan are lower than the other provinces. So this is probably an underestimate. So even if we look at Ontario and Quebec that are ahead of us, we are probably in that same ballpark. Next slide, please. And the reports of our death rates per 100,000. This has been slowly trending downwards as we came out of the Delta wave. And in the last 14 days, this is a very lagging indicator. So as much as Saskatchewan has shown some improvements, and we are now ranked 4th of the provinces in terms of death rates, following the provinces of Manitoba, New Brunswick, and Quebec. And we do know that each of these deaths are important to us as individuals and as family members, because these represent loved ones, and our hearts go out to them. Next slide, please. Just go back one. So this is a slice of our epidemiology, and just a quick snapshot that is up to early first week of January. I think this is up to January 4th, and it just shows even today we have peaked, or not peaked, we have exceeded the Delta peak in terms of PCR positives, and we believe our positive rates are still going up in terms of Omicron. The epidemic doubling time for Omicron is much shorter than that of Delta and is estimated to be between 2.2 to about 3.2 days. And in terms of actual case numbers that are reported in the province, we're doubling every 4 days. And our test positivity last week on Friday was about 25%, but I believe we are slightly higher than that today in the range of 29% test positivity. Next slide, please. And this is a slide that really compares all the provinces in Canada, and it really is trying to align and show what it might look like if all provinces were put at a starting case rate per 100,000, which started at the same value of 12 cases per 100,000. Saskatchewan is the green line on top, which is a little bit difficult to see because the lines are a little bit narrow. And the other provinces like Ontario and Quebec are the longer curves. And really, the summary of this just shows that Saskatchewan and Western Canada, so Saskatchewan, Alberta, BC, were kind of the last provinces to start surging during this fifth wave. But our rate of growth, if you look at the slope of the curve, our rate of growth is faster than the other provinces. And unfortunately, when we compare our public health orders across the provinces, Generally, the trend is provinces that have fewer public health orders seem to show higher rates of growth of the Omicron strain. Provinces that are ahead of us, like Ontario, Quebec, New Brunswick, can show us by looking at those other jurisdictions what we can expect. And for us in Saskatchewan, partly, looking at our percent of fully immunized and full coverage, where we are one of the lowest in terms of double vaccinated individuals with fewer public health orders. The fact that Christmas and New Year's, we did have little limitations on gatherings or gathering limits. All this potentially points to a period of rapid growth of Omicron, like has been experienced in our sister provinces. And the small sidebar there just lists test positivity, with Saskatchewan being somewhere in the middle, Alberta and Manitoba being ahead of us in terms of test positivity. Next slide, please. And in terms of hospitalization, we've also seen an increased pickup of our hospitalization rate per 100,000. Not surprisingly, those over 70. So circled in blue, or the blue line, that is showing a higher rate of admission due to this particular strain of COVID. But we're also seeing a pickup in the younger age groups, and this is the 0 to 4 age groups. Next slide, please. And by the end of December 25th, we exceeded 90% of Omicron positivity in our SNP tests. So for now, we are no longer doing that screening test on all COVID samples, but we're still conducting full whole genome sequencing or lineage surveillance, which will be done together with all the other provinces. And Saskatchewan submits about 570 samples per week for whole genome sequencing to just keep an eye on what's happening. But we are in excess of 90% of our results by the end of December were Omicron positive already. Next slide, please. So what this challenge in testing and data reporting has resulted in is partly as a result of this huge demand on PCR testing because of the sudden surge in Omicron, sort of the ability to track confirmed infections, which is really the traditional way we actually counted our COVID results, has really been lost. So we do understand that the daily cases and the case reports we gave might only represent the tip of the iceberg. And our teams of EPIs are really focusing more on trying to come up with a representation of COVID activity, focusing more on the severe presentations such as hospitalization and ICU or critical care admissions. But we do realize that those are lagging indicators. And as this is developed more, we will begin to shift the focus in our reporting. We believe, just looking at some of our defense reports, which you'll hear from John Fro, we may be at the start of an acceleration of our hospitalization, but ICU still seems to be kind of stable. But this is something that we can expect to be challenged, like we've seen in our other neighboring provinces in Canada. There is interest in terms of trying to see if we can apply different innovations for our rapid antigen tests, which are very ubiquitous and available in Saskatchewan. Is this another place that we can try and get a better sense and a grip on what's going on with our COVID and our COVID transmission in community? And again, as I'd said earlier on, our surveillance and reporting teams, and I have to add, our data analytics teams as well, are part of the team that are working on helping us review and looking at our reporting framework for COVID in Saskatchewan. Next slide, please. So this week, the government of Saskatchewan extended the existing public health orders. This is the mandatory masking in public places and the proof of vaccination orders to the end of February of 2022, but no additional public health orders were added with that announcement. But prior to that, in December, we had received notice of changes to self-isolation and quarantine guidelines, where cases, their isolation period was reduced from 10 days to 5 days, and for close contacts to a COVID case, if you were fully vaccinated, you remained exempt from any quarantine, but unvaccinated close contacts, their period of isolation or quarantine was reduced from 14 days to 10 days. The key message in terms of isolation and self-management is if you have any symptoms of cold-like illness or respiratory illness, or you feel unwell, stay home. Stay home regardless of these days that are put forward. These are guides, and this is really more in terms of maintaining and supporting safety of the community and our health services. And really, part of what is informing this shift in isolation and quarantine is really a balanced approach to try and support business continuity and a better understanding of the science and the transmissibility of Omicron, where most of the transmission is really front-loaded to the first few days of exposure and contact with a case. The belief is that by day 5, 6, 7, you would have either been infected and cleared it, or you will no longer be infectious and you can be released from isolation if you're a case. Next slide, please. So overall, our key message is Omicron in Saskatchewan is here. It's widespread and it's spreading rapidly. The other effects of Omicron in terms of human resource management is really complicating our overall pandemic response by introducing another emergency in terms of being able to provide service and business continuity overall. We do understand with this rapid pace of transmission and rapid rate of infection with a mild illness, not everybody will show up for testing. Many cases will go undiagnosed, but a lot of people who remain only with 2 doses of vaccine coverage or less will be at risk of infection. And we do know that the booster dose is important in terms of protecting you from the more severe effects. We predict that this is probably going to be the highest surge that we've experienced in Saskatchewan, and it will be different because it will come with staffing pressures affecting all sectors. And this is really going to be a busy time for all of us in Saskatchewan for the next few weeks. Next slide, please. So in terms of our surge planning for the offense, we do understand, even with the uncertainty around the Omicron variant, that this has already shown the propensity for large surge and large spread. And a lot of the work that we're doing in terms of surge planning for offensive work is, we are rapidly transitioning some of our overall responsibility for test, trace, isolate practices from our public health teams, just due to the sheer volume and size of the pressure, to other sectors and other individuals in order to keep ahead of viral activity and public communication demands as close to real time as possible. If we are to wait to get all the information before calling people, it might be too late. So the real overall shift is really shifting from an overall isolation and control strategy to a strategy that really looks at promoting a health promotion strategy that promotes self-testing, self-notification, self-care, and self-isolation approaches. So there's a lot of information and materials that have been put out by our communications department and public health departments to schools, to the public, to the general community in terms of how to use a rapid antigen test and how to respond to a positive rapid antigen test and what to do if you have symptoms. For our CD teams, we will shift and prioritize that work and follow up to following up outbreaks, and particularly prioritize work around congregated settings where vulnerable people are found, such as long-term care, personal care homes, and acute care setting. And if things get even more tight, we're moving more to just self-testing and self-sampling techniques as a way to continue to provide access to these services to the population of Saskatchewan. Next slide, please. I'll hand over to Dr. Wasco. Thank you.
Go to the next slide. And I have no disclosures. In terms of our uptake, so this map is now based on the population aged 5+, so those that are eligible to be vaccinated. As you can see, we still are hanging out in last place for both measures. Really not too changed from previous. Next slide. In terms of our uptake, broken down measures by the demographics, and these are the younger demographics that we're highlighting here because those are where we find that we have lower uptake rates. We are still making some progress, and particularly in those that are 5 to 11, although that has stalled a bit. We know that that's not just happening here in Saskatchewan, but across the country, that most provinces have stalled with their 5 to 11 vaccine rollout and are hanging out at around that 50% mark. In terms of our booster uptake, I think that has been the focus over the last month, roughly. And right now we're sitting at 41% of people aged 18 plus who have taken up the booster shot. But as you see in the younger age groups, the people in their 20s and 30s, that is much lower. Next slide. In terms of the surge planning and how the vaccine campaign is contributing to that, we are really pushing the mantra that every healthcare encounter is an opportunity to vaccinate. And that includes across service lines, within the health system, within the SHA facilities and services, and also for physician clinics as well. Both are important locations where opportunistic vaccination can occur. So someone coming for some other reason who is eligible for their booster shot can receive their booster shot in that setting from a provider who has it within their skill set to provide vaccination. So that could occur in an emergency department, an inpatient ward, through home care, ambulatory care settings, and of course in physician clinics in the community. The first QR code at the top there is a resource page that provides information about every healthcare encounter being an opportunity to vaccinate and is more SHA focused. So it's, work standards and so on that have been created to support that work, so that if, on your unit in your hospital or in your community, people are struggling to get things going, rather than recreating the wheel, we can learn from each other and be successful. The second QR code there is a link to the survey so that you can do the quick survey. It takes like less than 5 minutes to be able to send in the information to the Ministry of Health so that you can be approved as a clinic that can provide the vaccine. And then after approval, public health can be in touch with your clinic about providing the necessary support and supplies so that that can occur. And just a reminder that since December 1st, there is a fee code for provision of booster doses. There has been a fee code for counseling regarding vaccine hesitancy, as well as providing initial series. Longer than that, but there is also a fee code for providing boosters in the clinic setting. And just a reminder as to who is eligible for boosters. So everyone that's over the age of, or 18 and over, is eligible 3 months after their second dose. But there are also people born in 2009 or earlier, so that 12 to 17 age group is also included. If they have a condition that has deemed them clinically extremely vulnerable, and then they are also eligible 3 months after their second dose. So that includes conditions like diabetes, severe asthma, and cystic fibrosis, so on. There's several that are listed, and you can find those by looking up who was named eligible when that was first announced. And it also includes the moderately to severely immunocompromised that are eligible for a booster ongoing every 3 months. And for our long-term care residents, they are eligible for a booster ongoing every 5 months. And just for those of you who do long-term care, in February, we will come upon the 5-month mark from when the third dose of the boosters or the booster shots were rolled out in long-term care. And as well, with our surge planning, in addition to focusing on booster doses, we also are continuing to push the pediatric primary series. Obviously, we would like to see that getting much higher than a 40% uptake. So next slide. I'll turn over to Dr. Fro.
Thanks, Gavin. My name is John Fro. I'm the Defensive Strategy Co-Chief. My Co-Chief, Laura Garchinsky, is on the road right now, so I'm going to be presenting alone tonight. Next slide, please. I am a base medical director for STARS, but on a leave of absence. Next slide, please. These are our key strategic actions, which we've been updating on a every town hall basis. So we are developing and implementing operational and staffing plans to maintain acute and ICU capacity and prepare for surges. We're going to optimize low acuity care transfers from regional and tertiary to enhance load leveling and fully utilize our acute care capacity. We are going to develop a cascading provincial medicine capacity huddle. We are going to have to manage healthcare worker vacancies. Actually, Lord Garchinsky is actually right now on the road working on the ICU tiers of service expansion, where we're expanding to 110 beds in the province. Next slide, please. So just to orient you, this is our 4 integrated health service areas across the province. On the top left is North, on the top right is Saskatoon, bottom left rural, and bottom right Regina. As you can see, these are 7-day rolling averages, and you can see that from the dotted blue lines, in all areas we are having surges of COVID cases, essentially Omicron cases. There are a number of other lines here as well. You can see the non-ICU census in each of these. And the non-ICU census is also increasing. Excuse my dogs. Increasing fairly uniformly throughout the province. And we expect that to continue to increase. And our ICU is relatively stable throughout the province. Next slide, please. This is our provincial total medicine census capacity. And this was to date. Total capacity is 1,376 beds. Not all of those beds are operational. There are a number of beds that may be closed at any one time due to illness or operational challenges. But what you can see here is we call this our mountain slide, and you can see the total medicine census, which includes both COVID and non-COVID medicine census, and we are on an upward trend. Next slide, please. This is our total ICU census within Saskatchewan, and we've made some adjustments to this slide, but what you can see here is total ICU census, which is the top green line. Then there is a non-COVID ICU census, which contributes to the total ICU census, and the COVID ICU census. There are a number of zones in this graph, green, yellow, red, gray, and black. And we are currently in the yellow range there, and we are on an upward trajectory. The majority of our ICU burden right now is non-COVID, and we are keeping a close eye on this. Next slide, please. This is our ICU capacity slide. As I said in the previous slide, we are in the yellow within the provincial ICU capacity with a census of 79. You'll note that this is revised and informed by our experience through the Delta surge, and you'll see that there are some revised and updated and more fulsome accounts as to what our ICU is actually capable of in terms of actual realistic surge capacity. Next slide, please. So in summary, I think last time we said Omicron warning. This time we're saying Omicron incoming. We're seeing ICU demand being relatively stable at this point, but we are seeing an increase in non-ICU demand, both in COVID and non-COVID care. We are seeing that the system pressure is mounting, and looking at other jurisdictions and at modeling predictions, we anticipate to see a surge. This is an extremely infectious virus, and we are seeing uncontained spread at a previously unseen rate in our province. The unvaccinated remain at risk of severe illness and death, and vaccine and booster uptake are critical. We do anticipate that the unvaccinated will create the largest high acuity burden on our system. And we have to keep in mind that any additional public health orders will take weeks to have effect. So we are committed, I think, certainly at 2-week increments to what lies ahead. And I will end my report there. Next slide.
Mike Kelly, the safety officer for the SHA and EOC. Next slide. I have disclosures related to my other world and stroke research, none of which are at all applicable to this work. Next slide. It's been a busy week in 2 weeks in safety. 2 major changes this week, and you can get your phones ready because there's a QR code at the end. So SHA, we've revised our N95 respirator guidance. We're recommending that all providers, or the providers who are an N95 respirator when entering a room or space or within 2 meters of a patient, resident or client with suspected or confirmed COVID-19. And we've changed our droplet contact plus precautions. This applies, our rules apply to all SHA clinical and non-clinical staff, as well as affiliates and physicians working in healthcare settings. Next slide. This recommendation resulted from a few things, an ongoing environmental scan performed by our expert group. It was put in place out of an abundance of caution to ensure that people working with COVID positive individuals had tight-fitting masks. We want to emphasize that medical grade procedure masks still work, especially with double masking. And as I've been saying now almost for a couple of years, the infection control protocols, PPE is actually the smallest component of that. And I want to continue to emphasize that. Make sure that if you wear an N95 respirator, you're fitted to it and that you perform a seal check every time. Next slide. There may be some situations where physicians or staff choose not to wear N95 respirator based on point of care risk assessment. And again, we're really emphasizing, continue to emphasize the point of care risk assessment. We think over the last couple of years, this has worked very well, and that healthcare workers have become quite used to this and very good at performing this, where assessments of ventilation, the patient's presentation, type of interaction are all accounted for. Next slide. The other major changes around healthcare worker return to work guidance. So we heard from John Mark about The public healthcare workers, we're making several recommendations. One is, of course, to receive a booster dose as soon as possible. All asymptomatic healthcare workers should undergo screening with a COVID-19 rapid antigen test at least once a week is our recommendation. This isn't mandatory, but recommended. Healthcare workers with a positive rapid antigen test should have a PCR test done, and there is a process in place for expedited healthcare worker PCR testing. This is being prioritized. Symptomatic healthcare workers with a positive rapid antigen test but a negative PCR can continue to work and self-monitor. That's asymptomatic, sorry about that. They must continue to isolate for 5 days outside of work as per the public health order though. Rapid antigen tests are not to be used when people are symptomatic, and we know this is happening, but they're not intended for this purpose. And so healthcare workers with a positive rapid antigen test that later develop symptoms, but then have a negative PCR can return to work if the symptoms are significantly improved within 2 days. Next slide. So what does this mean? And this is related to the public health. Significantly resolved refers to when symptoms are notably improved for 48 hours. This recovery, as all of you know as physicians, can vary from person to person. Absence of cough is not required if there's a chronic or a lingering cough, wheezing, or shortness of breath. Then ultimately it probably comes up to many of you to make this determination for patients and yourselves. Next slide. So the other thing that has happened here is healthcare worker changes to the exclusion from work. So vaccinated healthcare workers who are COVID positive, first of all, must follow the public health order and isolate for 5 days. They're further excluded from the workplace for a total of 7 days. This is where we think 97% of the infectious period has already occurred at day 7. This period of time is either onset of symptoms or the positive test. A healthcare worker can return to work on day 8 if their symptoms have significantly resolved or improved and they have a negative rapid antigen test on day 7. If not, if the symptoms are not better or the rapid antigen test remains positive on day 7, healthcare worker is excluded from work for a total of 10 days. So the other way to think of this is healthcare workers are excluded from work for 10 days, but you can return to work early at day 8 if your symptoms are better and your rapid antigen test on day 7 is negative. Next slide. Unvaccinated healthcare workers that are COVID positive are excluded from work for 10 days. Next slide. So this QR code summarizes this week's safety bulletin, which outlines these slides. I'd ask you to scan it here. The other significant change that's happened is exclusion from work for close contact. So fully vaccinated healthcare workers who are exposed do not need to be excluded from work, but we recommend rapid antigen testing every 3 days. Fully vaccinated healthcare workers who are exposed to someone in their immediate household and had difficulty isolating from them are no longer excluded from work, but they must monitor symptoms, and we advise rapid antigen testing every 2 days. And unvaccinated healthcare workers who are close contacts are excluded from work for 10 days, similar to the public health order. And that date of exclusion starts from either the same date as the positive cases isolation. So one last time to scan the QR code. I'm happy to entertain any questions in the chat. Thank you.
Good evening, everyone. I'm Jessica Richardson, and I come to you from the Saskatchewan Medical Association with the Physician Health Program. Next slide. And I don't have any disclosures to report. Next slide. So I come to you today to talk about the new year, and with New Year's, Happy New Year to begin with. For me, it's gone by so quickly already. I can't believe we're almost mid-January. I don't know if others have had similar experiences. But with the new year, it's often been described that the start of the new year is the start of the next chapter in your book, and the pages are blank in your book, and you have the opportunity to create the content and fill up those pages with your story, with what's going to happen in this new year. And I want you to right now grab some writing utensils, whether it's pen or paper, if you want to use your phone and jot some things down. And we can take this time together to work on some ideas of what you might want to bring to the next year and some potential goals that you can work on. And don't worry, this is private. You're not going to have to share any of this information. This is just for your own benefit. Some people might approach the new year with optimism or excitement, whereas others might approach it with trepidation. And undoubtedly, the past 2 years have been exhausting. And as healthcare professionals, a lot has been asked of you to care for the people of Saskatchewan. And I want to say thank you for your dedication and for continuing to show up. And you are valued and appreciated. So thank you. There aren't many opportunities sometimes when you're feeling so taxed and you have so much on your plate to just sit and be still and have the opportunity to reflect. And so that's why today I want you to take this opportunity to be still and think about this last year and use it as a time for reflection. Sometimes being still can be uncomfortable for some people, and I can appreciate that. What it offers in being still is having that moment to ground yourself and consider what has worked well in the past year and what potentially could work better. And from the things that have worked well, are those things that you can integrate into the year moving forward. The start of the new year is a really good natural check-in point for people, and that's often where those New Year's resolutions and those goals start occurring and being created. So I want you to think over the last year, how are you doing? How did the last year go? It's a check-in point right now. In the past year, what has gone well for you? And I want you to write those down. Can you write 3 things down that have gone well for you in the past year? In relation to these questions, I want you to focus internally versus externally, meaning the aspects that are in your control. And I think that the entire population can pinpoint the not so well aspects of the last year with the COVID pandemic. However, these factors are the things that are out of our control. And despite the ongoings of everything that's happening, there have still been moments or things that have gone well. So I want you to think of what that was for you and how did you manage it? Was it something joyful that happened in your life? Maybe a breakthrough that happened? Did you manage well? Or did you maybe find some time for self-care? Consider these things in terms of what worked well and what you can continue to do and bring forward in the next year. Was it difficult to identify these things? If things don't work out as well as you had hoped, or what you had planned in 2021 wasn't realized, those goals, what did you learn about it? Exploring from the perspective of learning can help us grow. Rather than viewing the goal as not being reached or the plan was a failure, reframe it into, I learned blank from this. And if you're feeling uncertain about the year ahead, or frustrated or worried, or maybe ambivalent, that's okay too. Consider what is contributing to that. In the past year, there might have been times that life probably didn't go according to plan, and plans don't have to be rigid and black or white. And I want you to adapt that mindset to the year moving forward. If you can have an adaptable or moldable goal or outlook on life, then those perceived moments where there was loss of control won't feel as distressing. Ask yourself what is in your control, because stress is going to happen, it's inevitable. It's how you manage that stress that's within your control. So if there's anything that this pandemic has taught us, is that we manage the things that come our way. We just want to be able to manage them well and feel well at the end of it. Also, I want you to consider what brought you joy in the past year, and I want you to write that down on your sheet as well. And then what are you looking forward to in 2022? Next slide. Taking the components of all of that reflection, let's move it forward into goal setting for the next year. And I want you to think about what your goals are, both in short-term and long-term form. Can you bring forward the things that worked well and continue them in the next year? The short-term goals are really important, and that's the starting point. That's where we want to work from. They can be the building blocks to get us to our long-term goals, but they also provide us with an opportunity to gain some traction, to have some more immediate successes, and help us establish that habit-forming behavior that might lead us towards some of those goals, depending what it is. With the long-term goals, I want you to consider how you can have them being adaptable based on your circumstances. And by that, I mean not having a rigid end point of when you have to reach these goals. If we can be flexible, then when things go out of our control, then again, it's not that failure. It's that, okay, well, I will work on this when time allows. An example of that might be is that maybe you want to start traveling and you're going to start traveling when you feel that it's safe to do so. And so if that's one of your goals throughout the year, it's still attainable, but it's having this mindset to be able to adapt and meet it to your current circumstances. Now in the goals that you're writing down, so if you can write down 3 goals for this next year, what's the ones that came to mind first? Were they personal or professional? When you consider your goals, I want you to think about the personal ones too, not just the ones that are job or career related. Those are important, but the ones that are personal are the ones that tend to bring us joy. Balancing the goals is really important. Joy is just as important as success. It can even be argued that being more joyful and creating joy promotes more success. So finding that balance and incorporating goals that bring you joy will likely have a more enjoyable outcome and a more enjoyable journey. Personal growth is just as important as that professional growth. And sometimes that needs to be tended to first. And then lastly, allowing grace in your goal setting. And with that, it was that moldability and that adaptability when things maybe don't go according to plan. It's having grace with yourself and permission to adjust the plan, because life can go sideways sometimes, and we are left to try and manage that moving forward. Next slide. Now with this list, this wonderful list that you have started to develop, whether it's just point form or maybe you're going to go more in detail later, the most important thing that I want you to take away from today is that you need to pick one. Pick one item on that list. Sometimes when we have too much to focus on, it can feel overwhelming, especially when you're already feeling taxed. So I want you to scale it down to one goal, something that's realistic and attainable. And then this goal can be broken down into even smaller steps. So this is a photo, a stock image of Mount Everest and the various summits that you have to climb, so the different camps to get up to the top summit. Mount Everest is not possible to climb in a day. To reach the top, climbers need to plan to reach the base, the camps first, and then they go up to one camp and then they come back down, and then they're going to go up again and they're going to come back down. And what they're doing is acclimatizing to their environment. They're strengthening their system and their body to be able to build and grow to get to that next component or that next camp, strengthen themselves all the way to get to the top. Envision placing your goal at the top of that mountain. What summits or smaller steps do you need to undergo to reach the top? And conceptualize what those smaller steps are. When you get to those smaller steps or those camps, you got to celebrate them. Those are mini goals. Breaking it down can feel more manageable, but celebrating that success can help you feel that sense of accomplishment and continue to propel you more further towards your goal. And think of it as, when you get to that step, how can I strengthen this, and how can I maybe work on this for a couple weeks before I move on to the next goal? If you come back, it's just a learning experience. So conceptualize it in that way, of that personal growth. So an example might be is that in the next year, you want to sleep more. Many people can relate to this. We just want more sleep. So that could be a realistic goal, but maybe that feels really big. What might that actually look like for you? So if we were to break that down, maybe the first step would be that, okay, for the next 1 to 2 weeks, I'm going to limit screen time for 30 minutes before bed. And that even includes not checking my emails immediately before I go to sleep. I'm going to do this for 1 to 2 weeks. And then I'm going to assess and see, okay, where am I at with this? And I feel confident after 2 weeks, I'm building this and I'm gaining some traction. So the next goal after that 2 weeks is to maybe add on going to bed at a certain time, at a consistent time every evening. And then we're going to work on that for 1 to 2 weeks. And then we're going to celebrate that in 2 weeks when, hey, yeah, I did a really good job. Most of the time, even 50% of the time, I was able to get to bed at a consistent time that worked for me. The next step or the camp might be before bed, I'm going to do some gentle stretching. Maybe that'll help get me some more sleep so I can get into a relaxed like state before I go to bed. And then we work on that for 1 to 2 weeks. And I think you get the picture as you pick these smaller steps to work your way up to that end goal, the top of the summit. The last component is to reflect on that. So after 4 to 6 to 8 weeks, however long you've been working on it, sit back and think, how did this work for you? What worked well and what could work better? And then continue to build on that or maintain what you've already established. Those really strength-based, those components that you've really strengthened those muscles. Next slide. So these are some really quick tips and tricks, and I'm hopeful that you took some time to at least ponder them if you weren't able to jot them down. And if you want to take them further away and put some more effort into it, absolutely. As always, the Physician Health Program is here to offer some support. So if you're feeling that you need some additional support or want to discuss this further, I encourage you to reach out to Brenda or myself, and our contact information is here. Thanks again, as always, for having me here this evening. Have a good rest of your evening.
Thank you so much, Jessica, and thank you for reminding us, first of all, the importance of looking back and finding those moments of joy, and that the importance of joy as much as success. And sometimes it's the joy that's actually more important, I think. And I really like your way of talking about acclimatizing small tests of change. I'm going to draw everyone's attention to the live poll. I know we're at 7:30 and we're at time, but I'm just going to keep going just for just a few more minutes to wrap us up. Please answer the questions. They'll really help us understand how you're doing and how we can better work to support you through information and then working with partners across the province. And again, the importance of wellness and health. Reach out. We are really, I think, making progress in the ability to talk about how we're doing and find those actionable ways of taking care of ourselves, and that it's okay to not be okay. And when you need help, you reach out and we look after one another. My thanks to our partners. We'll just go to the next slide while people are doing the poll. Our partners are many, and the U of S, the College of Medicine, the CPSS, and the SMA have been alongside us throughout this, and they will continue to be, and I'm grateful. And I mentioned at the start how VITO has been, as part of the U of S, has really been there for us right from day one. They've helped us explore information. They've helped us explore all kinds of things with PPE, including recertifying and re-sterilizing our N95s when we were early on and the whole world was struggling with supply chains. Fortunately, we never needed to get to that point, but it was fantastic having partners who could help and guide us. Speaking of masks, I just want to help correct something that I think Dr. Mike Kelly might have misspoken, and he certainly did not intend to imply or infer or say that double masking is recommended or part of SHA safety protocols. The single medical masks, clean use, using all the right steps to use that mask is the approved way to use a medical mask. So just one at a time. Is there anything else I need to say to that, Mike?
I misspoke. Single masks, sorry. And thank you, Dr. Mueller, for pointing it out as well.
Yeah, it's great to get that immediate feedback and clarification. And with that, we'll move on to our next slide, because I also want to just say once again, thank you to Dr. Angela Rasmussen. You are absolutely an amazing scientist and speaker. I think I learned so much. I've been trying to keep up to date on understanding Omicron and not at the level that you understand Omicron, and I'm just so grateful that, first of all, you're here with us this evening, but most of all that you're leading the world in your expertise and your ability to contribute to the knowledge that we need to be the best we can in terms of safety and providing excellence in public health. The Q&A has been very busy. I think we've got over 50 questions going back and forth in the typed chat. We don't have time to bring out the themes this evening, but I do think there was so much valuable information in there. Most questions did get answered, a few didn't, but that will also guide what we need to bring forward for next time. So I heard a lot about vaccines. I saw a lot about even monoclonals. I saw a lot about further information about Omicron and what we do and don't know, what we might know next. That will guide us. And we'll move on to the next slide. We do have great news stories, so we're really working hard to have every point of patient care be an opportunity to talk about and provide vaccination, and this certainly is happening across our SHA programs and facilities. Many of you have been involved in our mass vaccine clinics and our pop-up clinics, and many of you have been involved in our community-based clinics where physicians in their own offices with their own teams have been partnering through the ministry and the SHA to be providing COVID vaccination right where patients are in your offices. And we think this is absolutely amazing. We're thankful, we're grateful, and as Dr. Wasko said, we are looking for more. So these are just some of the offices across the province and clinics where we know our family physicians and specialists have been providing vaccines to their patients, which is amazing. Please reach out and work with us to do more of this. And there are going to be further populations coming forward needing vaccines. So I am hopeful that we get approval for 12 to 17 in the near future. I'm expecting, as Dr. either Wasko or Takaya said, I can't remember, it was Dr. Wasko, that long-term care residents at the 5-month and beyond, we anticipate they will become eligible soon. And of course, we're waiting for the emerging science on vaccine safety in the ages 0 to 5 years less a day. And that's something that we're all looking forward to. And as this expands, we're going to need more and more and more people to be providing vaccinations to help in this coordinated response. So that's our good news story. It's happening. We need it to continue to happen, and we are grateful. Our next physician town hall is in 2 weeks, January 27th. I've told you before we were going to test going down to once a month, and that is just not possible at this time. You're telling us that you want these to continue, and we believe that we need them to continue as well. So our next one will be the January 27th. I'm not quite sure what our special topic will be, but I anticipate, based on the modeling, based on what we're seeing in other jurisdictions, and based on what Dr. Rasmussen confirmed for us and the rest of the science, we are going to be in the thick of it in a couple of weeks. We already are, and we anticipate that we'll be seeing more of this and more pressures on our acute care and our community system, and we need to stay informed. So between now and the 27th, I ask you to stay well, keep reaching out, looking after each other, stay safe, encourage everyone you know to get fully vaccinated, including that third dose being an mRNA, and we'll see you in 2 weeks. Good night.